Warm welcome to this masterclass on a clinical approach on long-term management of psoriatic arthritis. Joining us today is Dr. Samer Abu Ajamieh, consultant rheumatologist at Prince Mohammed bin Abdulaziz Hospital, Al Madinah, Munawara, Saudi Arabia. In today's masterclass, Dr. Samer will discuss the clinical approach on long-term management of psoriatic arthritis.
My name is Samer Abu Ajamieh. I'm a rheumatology consultant working in Prince Mohammed bin Abdulaziz Hospital in Al Madinah, Munawara, Saudi Arabia. I hold the German board for internal medicine and rheumatology, also the Jordanian board for internal medicine and rheumatology. I am a member of the Saudi Society for Rheumatology and a member of the German Society for Rheumatology. I'm practicing now as a consultant since more than 12 years. I practiced in Jordan and since more than 12 years also practicing here in Saudi Arabia. Taking considerations about the long-term therapy, we should think which medication that can give the patient a long-time remission. This is what we always think about, and to be able to keep the patient steroid-free, and also help him with his skin manifestations. Well, for the diagnosis, we have two types of psoriatic arthritis, mainly for our practice, the peripheral and the axial. And the peripheral also, there are several types like predominant DIP or oligoarthritis or polyarthritis rheumatoid-like and arthritis mutilans. So when we are speaking about the peripheral arthritis, in my practice, I rely on the Casper criteria, if you know them. The Casper criteria helps a lot in putting the diagnosis of peripheral arthritis. And the main point, of course, if there is a personal or family history of skin psoriasis. And in the axial type, we depend on the ASAS criteria. So the examination of the patient, the complaints, the X-rays, the MRIs. So we take in consideration for the axial, the ASAS criteria, and for the peripheral, mainly the Casper criteria. Monitoring the disease activity it contains more than one thing. First thing, the patient's complaints. We should, when we do follow-up, see how's the patient's doing after we initiated the treatment. Is there improvement or not? Are there still swollen or tender joints or not? Did his skin manifestations also went into remission or decreased at least or not? Also, if the patient is having fatigue or not. So in general, the complaints that the patient with psoriatic arthritis had. Plus, we monitor also the lab investigations, CRP-SR. We monitor also if there will be X-ray changes. And of course, we should look for any side effects of the drug. Yeah, these are the main issues. And the physical examination, if there are swollen joints or tender, or there is a limitation of motion, we take all these points into consideration. On long-term management, of course, we need disease-modifying anti-rheumatic drugs. In case of peripheral arthritis, I like to start with methotrexate. But in cases of dactylitis, enthesitis, or axial involvement, we usually start in these cases with anti-TNF-alpha drugs. Yeah, this is what's the first line we consider. Of course, we follow up later and see whether the drug is efficient and working or not. If there is peripheral arthritis, we start usually with non-biologic DMARDs like methotrexate or leflunomide. And we can also make a combination with sulfasalazine. But when we see that the patient has dactylitis, enthesitis, or axial involvement, then usually we start immediately with the biologic drugs. Well, okay, the options now that we have first thing the anti-TNF alpha blockers. We have 5 drugs. These are the adalimumab, etanercept, infliximab, the certolizumab, golimumab. There is no peripheral one, but I usually don't use the etanercept in psoriatic arthritis because it doesn't affect the uveitis. I prefer the adalimumab or golimumab or infliximab to start with one of these 3 anti-TNF alpha drugs. And we follow up the patient later. If the patient flares, then we can either shift from one anti-TNF alpha to another anti-TNF alpha, or we can shift to another class of biologics. Now we have the anti-interleukin 17 drugs. For example, we have the ixekizumab and secukinumab. We have also an option which is anti-interleukin 23/12, like ustekinumab. And nowadays also we have the anti-interleukin 25, like kuzilkumab. These are the main biologics that in my practice I use for treating psoriatic arthritis when we are speaking about the biologic drugs. But we have now a new group. This group, some doctors, they mix them up with the biologics, but they are not biologics. They are targeted synthetic DMARDs, targeted synthetic disease-modifying anti-rheumatic drugs. And these are the JAK inhibitors, the Janus kinase inhibitors, like tofacitinib, upadacitinib, and baricitinib. So we have also these drugs as an option. What I want to say, in my practice, usually patients with psoriatic arthritis are more hard to treat than rheumatoid arthritis, more hard to get them into remission. And even when we get them into remission, unfortunately, the remission doesn't last long like in rheumatoid arthritis. So we need to shift the patient from one drug to another more often than in rheumatoid arthritis. So in my practice, I have many patients with psoriatic arthritis where I shifted from one TNF to another TNF. Then we shifted to anti-interleukin 17, then 23/12. Then we shifted them to JAK inhibitors and to another JAK inhibitor. And sometimes we even go back after several years and start them again on anti-TNF. So patients with psoriatic arthritis, some of them are really hard to treat. Yeah, this is my experience.
Thank you, Dr. Samer, for your valuable insights.